Many people on GLP-1 injections post on message boards asking other patients for advice and their experiences. Well, we'll get those answers now from 3 board-certified physicians who are specialists in weight management and prescribing these drugs. From Tulane University Medical Center, bariatric surgeon Dr. Shauna Levy. From Kronos Body Health Wellness, owner Dr. May Scott, an emergency medicine specialist treating weight and aging symptoms with hormone replacement. And Dr. Tom Lavin, a bariatric surgeon who specializes in medical weight loss at his clinic, Supportive Wellness and Aesthetics. He's also the owner of Galleria Medical Pharmacy that is compounding GLP-1s. And welcome to all of you. Okay, we have a lot to get to. So first of all, what has been the overall experience with your patients? Let's start here.
Well, we've seen a lot of amazing results with this medication. Patients are losing significant weight loss, but you have to make sure that you're using the medication appropriately. There are patients who are just trying to lose weight without an appropriate diet or lifestyle changes. That's something we want to be careful about.
So that's part of your treatment protocol. Yes. Is here's the injection, here's the number of units, but what do you tell them? You also need
improve your diet, exercise, make sure you're getting enough protein and fluids with this medicine.
What about you, Dr. Levy?
Well, I mean, as you know, I've discussed before, this is a game changer in terms of weight loss medications. You know, for so long, you know, if you didn't want surgery and you wanted to take medication, we've been left with mostly stimulants, which made people feel, you know, like headaches and heart palpitations. Well, the GLP-1 medications come with very few side effects and have been able to lead to huge amounts of weight loss for patients.
So, Dr. Lavin, you've seen this as a game changer in your patients as well?
No question. It is a very safe peptide that, when managed with, someone overseeing the hydration, the intermittent fasting, it helps take away the hunger and cravings and lets patients fill up on a much smaller amount of food so they can have very significant healthy weight loss and get rid of their medical problems associated with the obesity.
Okay, so let's talk about side effects. First of all, we'll start here in the studio, short-term side effects. I understand that the nausea and those type of things, well, just for the first 30 days as you're titrating the medicine up, have you found that?
Yes, nausea is the most common side effect that we're seeing. And most people do get used to the medicine and the nausea does kind of dissipate at some point. But we're also seeing acid reflux, constipation, which I really think is associated with dehydration too. People just are not getting enough water frequently when taking this medicine. Some people get diarrhea and some abdominal cramps, but by far most people tolerate this medicine very well.
And what do you prescribe? What do you do for patients, Dr. Levy, who get these side effects?
I just want to reiterate that constipation I'm seeing as the most common long-term complication. Yes. And I agree with you, because when people are not hungry, they're also not thirsty. Yes. And so that's one of the #1 things that we prioritize the patients, that if you have to choose between drinking and eating, drink, like fluids, sugar-free fluids, so that you can stay hydrated. I always send my patients home with Zofran when we send the initial prescription. But the thing about Zofran, it can also cause constipation, so we have to be leery of that and be careful. We want to make sure that patients are still eating their protein and their fiber and drinking water, because even though these medications are extremely powerful and lead to weight loss, they don't necessarily make you make good decisions, right? You have to pair that with the decisions that you're making in order to fuel your body with appropriate intake.
Now, Dr. Lavin, we talked about you having a compounding pharmacy, and your compounding pharmacy is making the semaglutide, and you've said that you added a vitamin B, and that's lowering the rate of people who have the nausea?
There's no good data on that. We've used B12, and sometimes we don't use anything, but what we create is the same peptide that is on the market, and we buy from FDA approved distributorships nationally. So we've gotten very good results, and all these patients are being managed by weight loss doctors. So I would say it's debatable whether the B12 actually decreases it. it's more patients say that, but there's no good data that can prove that.
About 48 hours after taking the dose, they have some subtle nausea, maybe during the day until they eat something. And it's really not usually long enough to require any medication. It does last more than a month, because you mentioned a month. To me, it lasts until they're done updosing. You know, so if they updose over a 5-month period or something like that, then that's how long the nausea lasts. But the longer you're on a medication, the less likely you are to have side effects.
So it's a little queasiness. It's not actually like you're sick and you're vomiting.
Unless you eat something that disagrees with you, you know, because you become much more sensitive to high fat foods or high sugar foods, which can lead to more nausea and the diarrhea that
Well,
you
that's
mentioned.
interesting. Some of the patients we talked to earlier said they know they have just stopped choosing to eat high sugar food because they know they're not going to feel good.
It does make them nauseous. Yes, we have had some patients that just cannot tolerate this medicine because of vomiting, nausea and vomiting, but that's pretty rare. The majority of them do have intermittent nausea, and it does seem to improve after a few weeks.
Are you all noticing a difference in semaglutide that hits one receptor and tirzepatide, which is the Mounjaro and Zepbound that hits 2 receptors, is more better? Is the one that hits 2 receptors more effective, Dr. Levy?
Well, the studies clearly indicate that the weight loss potential is higher with the tirzepatide than the semaglutide, and 22% average body weight loss versus 15%. We also see that some of our patients have less side effects with the tirzepatide. It may have something to do with that second receptor that you mentioned that's included in the medication. But I don't, as far as I know, there's no head-to-head study.
Okay.
Yeah. I've seen the same thing. We're seeing less nausea overall. I'm still seeing constipation in both of them, but the nausea seems to be improved with tirzepatide.
There are some people who say we don't have long-term studies, even though this started being researched 19 years ago. So, Dr. Lavin, let me turn to you. Are you concerned about long-term side effects? I know we've seen good cardiovascular studies come out, how it helps with kidney problems, fatty liver, that type of thing. What do you tell people who say it hadn't been on the market long enough?
Well, they appear to be very safe peptides that, you know, once again, need to be managed by a real weight loss doctor. And I just want to add, we have people drink so much water, you know, being in a bariatric surgeon, we've always really pushed that. So we really try to encourage a lot of hydration. And the bigger problem we see is more of the reflux secondary to delayed gastric emptying. So sometimes these patients will need to go on Prilosec, PPI for a short period of time. But as far as long-term problems, the long-term problems of having high blood pressure, diabetes, obstructive sleep apnea, the heavy amount of medical problems that come with the weight, there's no way that there would be a long-term problem that would outweigh the health and life deterioration of people with keeping the weight on. So you can never tell long-term, but I feel really good about these peptides long-term and really changing the health of the country for people that are on them and are managed by weight loss doctors.
Okay, can people drink alcohol while they use these? What we're reading is there studies are being done now where they're starting to see that reward center in the brain. People don't want as much alcohol. People don't want as much sugar. People don't want to bite their nails as much or pick at their skin. And those are being studied. The science is still out on that. But what about having some alcohol while you're on these? Do we know if that will hurt your liver because your liver has to work harder?
Well, we worry more about the pancreas because alcohol is the #1 cause of pancreatitis in our country. And these medicines do irritate the pancreas. There have been some episodes of pancreatitis with this medication. So we do have to be concerned about that. But as you mentioned, they definitely do decrease or seem to decrease the cravings for alcohol. Yeah.
And what about, we see so many celebrities and they have 10 pounds to lose to get ultra thin. When patients come in and they want to look good for the reunion, 10, 15 pounds, what does a good physician say to him or her?
Problem with doing something like that is you're desensitizing your body to the receptors, right? So if you go on the medication for like a short period of time to lose 10 pounds, if you do it again, your body's going to be less sensitive to the medication. It's going to be harder for you to lose that weight. So you're really just setting yourself up for problems in the future of making it harder every single time you want to lose weight. So it would be better just to keep the 10 pounds than to use the medication to lose 10 pounds, then come off of it, gain the weight back, try to use the medication again, because it won't work.
Yeah, the medicine just won't work as well. And also people with lower BMIs, it doesn't work as well. The medicine is not going to help them as much as it would someone with a higher BMI.
And frankly, that's why people with diabetes with lower BMIs can take medicines that are Ozempic without worrying too much about being incredibly low weight.
And Dr. Lavin, you have strict protocols on what the BMI has to be, a body mass index, and if there are any comorbidities, meaning other health problems, before you'll prescribe the semaglutide to these patients, correct?
Right. We're sticking with the rigid FDA guidelines right now. My expectation is over time, as they find improvement, people getting off alcohol or cardiac benefits long term, they may lower these requirements. But absolutely, there's a desensitization, as they were talking about, where patients, these won't be as good for them later on if they use them for 8, 10, 12 pounds now. So yeah, we absolutely have criteria.
And what are you finding with a muscle loss or body composition, Dr. Lavin? Are you finding that people really are losing fat and then they're changing their diet to lift weights and that type of thing to keep their muscle?
Well, I really recommend everyone do some kind of weight exercise, as we're finding that muscle mass long term is one of the best indicators of how well you're going to do as you go into your 70s and 80s. So I think the muscle wasting is something where people don't work out at all and they just go in a catabolic state and don't lift weights or don't do any kind of exercise. And we definitely don't recommend that. We try to really get people to embrace their own health, drink a lot of water, get good sleep, lower alcohol, definitely don't smoke, and lift weights. So we push everything.
I read a study where people are actually choosing more healthful foods in the grocery. So one more line of questioning for all three of you. You see commercials on TV. Go to this website and we'll get you your semaglutide, your tirzepatide. Then you hear about, I've heard about counterfeit places. Come to my house and I'll sell you some out of my house or online. What is the best advice for each of you to make sure, for people to make sure they're getting the actual medicine, and that there's been shortages of the prescription of the non-generic form, the name brand form, but the compounding pharmacies, how do you make sure you're going to a reputable one? So we'll start with you, Dr.
That's something
Scott.
we were talking about as well. We do use compounding pharmacies, but every compounding pharmacy we use does third-party testing, which means every batch they make, they send a sample off to have a third party test it for potency and sterility to make sure there's no infection, no endotoxins. That's very important to us because there are so many compounding pharmacies making this medicine. You have to be very careful with it these days.
And do you, people going on a TV commercial and doing a telemedicine visit, how do you feel about that, Dr.
Yeah,
Levy?
I mean, I think one important point is that obesity is a disease, right? And so when we're treating patients off of commercial or just ordering something randomly online, you would never do that for another medical condition, right? You would go to a doctor, you would go to a medical professional who could assess you and treat you and discuss about the risks and benefits and consider your other medical conditions. It should be no different with obesity. So you want to be very careful when you're choosing how to treat a medical disease.
Yeah. And Dr. Lavin, you have Galleria Medical Pharmacy, and yours, the prescription you are compounding, you know is the correct medication, and that is helping people with the high cost who don't have insurance pay for it.
Right. And getting back to your question, you definitely want to buy from a compounding pharmacy that buys from an FDA registered, inspected facility, number one. Number two, they'll have a certificate of authenticity associated with that. And of course, they do sterility testing, which really you have to do under the state board and is the right thing to do. So those are the things you need to look for, because there are these sites that will sell these compounds or supposed compounds over the internet. It's for animals only, and so there's a lot of bad places you can get the medicine. So that really needs to be checked out.
Okay, and I guess further advice would be don't ever go to somebody's home or hotel room or something and buy anything. Doctors, thank you so much all for your insight. Coming up, you've lost weight and now you're dealing with loose skin on your body and your face. So what do? We have personal stories from patients and then answers from experienced board-certified plastic surgeons and a dermatologist who will explain and show pictures of what can be achieved. Stay there. You've reached your goal and lost weight, but as we know in many people, skin on the face and body usually will not tighten back up. But before we talk to our expert physicians about fixing that, Catherine Wilkinson and Susan Sneed-Dupont are here with their personal stories. I really appreciate y'all coming in, and we're going to be showing pictures too, some befores and afters. So, Catherine, you have lost 107 pounds. That is, how do you feel? You must feel completely different.
Completely different, and much more in tune with my body and much more capable of using my body to the fullest, because it was just very limiting in terms of mobility, and with exercise and activities, running, jumping, climbing trees, backpacking, hiking, all of these just basic things, sitting in a chair, walking around, standing, everything is improved.
And only in your late 30s, so a lot of living to do. Now, you had semaglutide and some other oral medications, but you said that the skin, the extra skin on your stomach, was actually painful. How so?
So there were impacts in terms of rashing, in terms of pulling on my low back, and since surgery I've been able to, or I've noticed that there's been a decrease in migraine activity. There was ongoing pressure on the bladder. There was, if I needed to run or move quickly, it was more painful when it was bouncing out of control without significant layered shape wear and compression wear. So there was always some kind of garment to
This wasn't
hold
about
it in
having
place.
a flat stomach and a bikini. This was, there were many other reasons to have that.
Absolutely.
Was it a hard decision to go in and have the tummy tuck, because you had the muscles tightened as well, the skin
Correct.
removed, muscles tightened. How was that recovery?
That recovery with the muscle repair honestly was more painful than labor. The skin repair in and of itself was an absolute breeze, and I felt immediately better following that procedure.
Yeah, and clothes fit differently, I'm sure.
Clothes fit differently. Clothing options have opened up significantly. I've historically not worn pants, leggings, shorts, or anything to that effect because of the profile and being able to match. But as far as clothes that I've always wanted to be able to wear, costuming in terms of celebrations in the city, the world has opened up, and the options to be able to wear and engage with what I would like to wear and how I'd like to present myself to the world has been significant. The stress by itself was not one that I would have been able to pull off prior.
And Susan, so you recently lost 80 pounds.
Right.
And you wanted to focus more on your face.
Right.
And you just recently had some filler put in your face.
Right.
What was bothering you? What had happened after the weight loss?
Age is one thing, but also with the weight loss, it was over a 2-year period, but still the elasticity was like a gobble. I call it a gobble.
Turkey neck, they call it.
Right. And I tried other treatments, lotions, everything, and it wasn't getting any better. I still, have some of this looseness on my arms and different little places, but I didn't have the stomach. I've never had children, so I don't know if that's part of it, but I didn't have the stomach that a lot of people have had.
So you turned to a doctor and you said, what can you do? And you started not with surgery, you started with injections. Why did you choose that?
I wanted to try the less invasive, something that was gonna see what that would do before I would like go to surgery, like see if there's something more simple. And then, so they have different treatments. They have the Morpheus, which helps the collagen production, and the tightening. They have the fillers, and then of course, like the Daxify, which is like Botox.
So, so your route is going with the injections, the fillers,
Right.
and also with different machines,
Right.
radio frequency that can tighten
Right.
skin and that type of thing.
Right,
Okay.
all of those. I've tried, over the last year, and then now more. Like I've added different things.
So what would your questions be? Because we're going to be bringing on experts, physicians who take care of these type of needs. What questions would you have for them and your friends who've lost weight? What do you want to know about tightening skin? You brought up arms, Susan.
Right, I talk to them about different. They do have different treatments for that. I have options because of the crepiness. But I was always one that had a round face, and every diet I did, I still had a round face. It didn't matter if I lost 40 pounds, it stayed round, and I had a double chin. And with the GLP-1, my face was the first thing that lost weight.
Thank you, ladies, for explaining your story and for showing us your before and after pictures and continued success in your health journey. Thank you very much. Doctors call it redundant skin. You and I call it extra sagging skin that we don't want. So what works, what doesn't, and how can you get the most for your out-of-pocket dollars? Well, here with us are 3 board-certified doctors who are specialists. First, Dr. Mary Lupo. She's a dermatologist who is often on the forefront of clinical trials for new procedures. Dr. Cameron Kubehi, a plastic surgeon in private practice, who's a pioneer in moving your own fat from one area to another. It's called grafting. And Dr. Cynthia Mizgala, a plastic surgeon, also in private practice in the New Orleans area. All of them. Welcome to you. Okay, we have a lot to talk about. Dr. Lupo, let's first talk about you're not going to do surgery on people. You're going to help subtle changes. So for the face, what can be done?
We do hyperblended radiesse, we do Sculptra, and we do Renuva. And the beauty of Renuva is it is an acellular fat matrix that is biostimulatory for fat.
So you will add some of your own fat in the good places where you want it to lift your cheeks or that type of thing?
What this does is this biostimulates your body to put your fat in that area. So it is telling the body, put fat here, while we're perhaps taking it away somewhere else.
Because you have patients, as I call it, Ozempic face, who come in it and they're gaunt, it makes them look
Exactly.
old. Okay.
The thing that will make you look the most gaunt is temporal fat atrophy. That is when you get a severe hollowing in this area, the temple. And the reason that that's so bad is that there's nothing that gives you a more aged appearance than temporal fat atrophy. In addition, it narrows the upper face. And typically these people are still a little bottom heavy. So you end up, if you don't address the temporal atrophy, you'll end up with what's called the peanut head, and then it gets bigger. And then a heavy bottom face for women is a masculine look, whereas higher here and here is a feminine look. So it's about using a product to optimize the patient's appearance. So it's critical. In addition, when you have lipoatrophy of the temple, it drags down the lateral brow. Every woman wants a lovely arched, you don't want a cat eyebrow, you want an arc because you don't want it to look like McDonald arches.
The point is you don't just want a doctor, you want someone who understands the anatomy of the face. To our board-certified cosmetic and plastic and reconstructive surgeons, are y'all seeing more and more people come in who have extra skin because they've been on these GLP-1s, Dr. Kubehi?
Yes, we do, and there's a couple of things that when the patients they start on this pathway, they need to know. One of the things is that if you lose more than 2 to 4 pounds a week, you're going to have sagging for sure because the skin is not going to track. 2, one of the problem is that patients go on with medication, they don't eat enough protein, and that's one of the things that lose muscle mass. And one of the things that we notice also is that called Ozempic face, but there's Ozempic butt. because they use the muscle mass in the butt too.
I've seen postings, they call it pancake butt. Yes.
Because patients don't exercise, they go on the medication, they lose the weight, but not in the right way. They don't replace the protein, they go kind of too fast, too much, and then having issues with this muscle mass loss. And then the plastic surgeon has to come in. We cannot replace the muscle mass, but we can replace the lifted tissue, remove the skin. And these patients, they have lost so much tissue that you have to do the arm lift, face lift, butt lift, and also replacing the fat, using the fat as an enhancer.
But let's be clear, no matter how much you exercise, which you should, and you should still build your muscle, it cannot fix sagging skin. It's like when a woman has had a baby. The sagging skin, no matter how many sit-ups she does, she's going to have the extra skin on her abdomen, correct, Dr.
Yes,
Scala?
and we get that question a lot from my patients, and sometimes when they're considering surgery, they think, well, I'll just work out more. And that, like you said, there's a misconception that working out is going to tighten your skin when it really doesn't. It might enhance the muscle mass, so make the appearance of the anatomic area look better, but it's not going to tighten skin no matter what exercise you do. And after pregnancy, someone's skin bounces back, and other people it doesn't. In that case, there's really only one option, and that's some type of tummy tuck, which means an excisional procedure because of that.
Okay, so let's go from bottom to top. Are people having thigh lifts and that type of thing after this? And I want to hear both from surgeons, and I want to hear about what injections can do on knee sagging. Let's first talk about the thigh area that's sagging. What can be done?
First of all, this is not something new. We were exposed to this with the gastric sleeve, gastric bypass. These are the patients that they lost 100 pounds, 150 pounds, and they end up having that kind of body lift, circumferential body lift, making an incision all around. And usually what you do with the upper body first, and then you go to a thigh lift, which some patients need the inner thigh lift or medial thigh lift. But this is continuation of that weight loss. And we cannot do anything, get to the point that there's so much skin that you cannot use all the modalities Dr. Luba talked about because they've gone past the point of no return.
So the point is, find a board-certified cosmetic surgeon, plastic surgeon, who has done a lot of these with the bariatric surgery, who has experience.
I agree totally, because bariatric surgery became in vogue when I started my training, and it became really popular, and we became very busy for the same reason that the skin just isn't going to go away with exercise. And many new techniques were researched and developed, and it used to be a big thing, and blood transfusions and hospital stays. Now it's outpatient surgery. You know, anything we do, we can do better next year, and learning as we go. And of course, safety first. You want to make sure these people are nutritionally sound. I do extensive blood work, all the vitamin levels, everything we did for the bariatric patients, we want to do also for these people. Ironically, also, you know, as Dr. Kubai said, it's gone from kind of surgical weight loss to non-surgical, and now we're going from non-surgical to surgical to help these patients.
And no smoking too, because your skin doesn't heal, doesn't get the oxygen.
Right.
Dr. Kubai, I've seen before and after pictures where you have enhanced the buttocks with moving fat grafting from one area to the other. And does that last?
It lasts because what happens is that, first of all, one more important is that if you keep your weight stable, yes, it's going to last. But if you lose weight, you're going to lose that fat too. So that's very important. So when the patients come in for discussing about doing the procedures, our main thing I ask them is that, are you stable? Because you want to make sure you've been stable for 3 months at least on the injections or off the injection, but you want to be maintained. Because if you do the procedure and then gain your weight back, that's another problem by itself. So main thing is that being stable and also getting to the nice place in your life that you are comfortable with your body, and then do the procedures.
Okay.
And then when you're doing a fat injection, we do it for the breast, for the face, for the body. It lasts, but is it going to change with you? If you lose weight, is it going to lose? If you gain weight, is it going to come back in another nice way?
And Dr. Lubo, how much difference can you make in like sagging skin on the knees by putting filler in? A little bit of a difference, a lot of difference?
So there's different responsiveness from person to person on how you will respond to the biostimulation. Again, I think that things like the hyperblended radius and the sculpture are really more for excessive crepiness rather than real redundancy. But I'd like to make a point. It is extremely important for these patients to exercise. And I'll tell you from my perspective as a dermatologist why. When you are not eating enough protein and increasing your muscle mass, you are going to be a setup, because your metabolic rate is really determined a lot by your muscle mass. And if you've lost fat, but you've also lost muscle, it will be easier for you to gain weight after you stop the medicine, if you stop the medicine. And I think that really needs to be emphasized. In addition, protein malnutrition, because you are eating less, causes hair loss. And women hate to lose their hair. And this is a big part of what I do in dermatology, is help women. And there's a lot of blood tests that we do, and there are techniques that we do. And I hate to say, you know, this is the panacea for everyone, but there are lots of options out there. But try not to have it in the first place. Don't be in too much of a catabolic state. Build muscle, make sure you're getting protein all the way through it.
No, excellent points. Okay, let's move up to the breasts. I know both of you have done many breast surgeries, lifts on patients who have lost a lot of weight. Breasts are fat and glands, and when you lose weight, they're going to absolutely change. How often are you seeing patients come in needing a breast lift after they've lost a lot of weight?
A lot more. And of course, we have a lot of experience with that, because even without weight loss, with pregnancies, that can happen as well. So again, we're adapting techniques that we've known for many years to this specific subset of people. And the only difference is, of course, to make sure they're nutritionally stable, do a proper workup, but basically the same techniques. And there are different types of breast lifts, and there are different types of ways to fill the breast. As you mentioned, Dr. Gabay is a world expert on inventing or perfecting the fat grafting technique for breasts. So some women elect not to have an implant and use their own autogenous fat, if they have any left, you know, with the weight loss journey. And then basically with breasts that are sagging, it's a proportion thing. We want to either fill the empty pocket, you know, like a deflated balloon. We either want to fill the balloon, or we want to trim the balloon, like trim the brassiere of the breast, which is like the skin brassiere of the breast. So that involves different types of breast lift or different types of fillers. So fat, saline implant, silicone implant for filler, and there's different improvements in those areas. The new gummier breast implants are a lot more tolerated by patients. And then there's different types of lifts, always trying to balance the burden of scar versus the improvement in the result. So I always go through the steps with patients. Step 1, supra-areolar, we're just lifting the nipple. Step 2, lollipop. Step 3, a full anchor type, so that you're tightening the breast this way and this way. So it's like an anchor.
And Dr. Gabay, you've done a lot of the tightening of the skin on the arms, cutting out skin on the arms, and the breast lift. And the scars are well hidden, except on the arms, that's a little trickier with the scars.
It is trickier, but with the advent of with the progression in the laser treatments, it really helps a lot. And like Lupo kind of pioneered in doing the fraction and all these treatments, but that really helps to kind of treat the skin. You cannot do the procedure and forget about it, because the scar is going to heal different in different people. Darker the skin, more scar tissue. And then you have to use some kind of, either you have to get silicone gel sheathing, or you're doing some kind of laser treatment, a different kind of laser treatment based on the skin type. You have to treat that, and that's having a good dermatologist in your friend helps.
And on the breast lift, you can lift the breast, but if they're still a little empty, you will do liposuction on the fat, and you will then put it back in the breast to create cleavage. Or even if someone chooses to get an implant, you can still put fat around it to give cleavage.
Correct. One thing is that we have noticing the trends. There was a trend that there was a large implant was in, but now we see that it is number of the implant is used in the United States has gone down a lot, or the size of the implant has gone down. There used to be 400, 500 cc, now it's gone to 200, 300 cc. So that makes it a little bit easier for the patient. They come in and they're looking more for not the size, then the lift and some fat helps with the cleavage. That's a good combination. But then you get to the point that some patients don't have the fat, don't have that, so you have to use the implant. But as much as possible, try to use the patient own tissue, because It is safer, if you want to put it, because you own tissue, but also it look more natural with the touch and feel of it. So the fat, and also one thing advantage is that you can put a little bit more in the cleavage area, and also, and Dr. Liu was talking about that using the artificial fat, also that, so it is, we found out it's a great tool that we have to add in. And one of the things that makes the people look beautiful, men or women, is appropriate amount of the fat in the face. Not too much, but not too little. And one thing with the aging what happens also is that we lose a lot of fat in the face. If you look at your grandma, your grandpa, you will notice that they have lost the fat in the face. So it's a great tool. Fillers are great, but one of the tools we have. But also using the fat is another tool.
And the fat being put in the breast doesn't interfere with mammograms or anything of that nature?
It does kind of interfere to some degree, but that's why you have the radiologist be qualified to read that one. But it does much less than the implant.
Okay.
And also, if you have one starting point mammogram and then a year later, that really helps to kind of keep an eye on that one.
Dr. Misgallo, on an emotional level, what do these patients tell you? They've been through so much, 170 pounds, when they were heavy, and then they've lost this weight. The world treats them differently. And what's going through their mind, their heart and soul when they have all that extra skin that they just don't want anymore? Do their families say, oh, don't do it, you look fine, you're thin?
All of the above. So I think that it's life-changing for a lot of my patients, and it brings tears to my eyes to hear their stories. And I remember one patient, way back when we were starting with bariatric surgery, she lost 200 pounds, and she was about 29. And she told me the story if she would go into a shopping or whatever, and she would see like cars parked together, and she would walk around thinking she still was 300 pounds, like thinking she wouldn't fit. And it takes a while for their body image to adjust. And when they finally do, to some degree, yes, it is disconcerting that we have to do the second stage, but it's also such a wonderful adventure. And sometimes it is a bit overwhelming because, like you said, it's kind of head to toe sometimes. So when they do present, I go over the whole excitement and congratulate them on their journey and their health. And then we do an assessment, and we're trying to get the best outcome in the short, in a shorter time period, so they can really feel like they've completed their journey. So we try to stage things. So I might do breasts and arms, or breasts and tummy, then maybe come back and do the thigh lift and something on the butt. We really go over their priorities. What bothers you the most?
And I promised the patients we spoke with a little while ago, we talked about cool sculpting. Dr. Kubehi, that's more for pockets of fat that don't respond to weight loss, right? That's more for sculpting? Or can you get rid of extra fat, or is it more just for a little bit?
It is a little more targeted area treatment. It is not more for whole body weight reduction or in treatments like that. One, it is not practical. Two, it's become too expensive. Two, it's not as effective. And so it is good for certain problematic area, love handle area or the neck area. There's some area that you're more specifically concerned about. I just want to add one more thing about that in asking about how we fix the patients, that new medication, semaglutide or Ozempic, Manjura. One thing, I did use it myself. I lost 25 pounds. And really, I never thought that I'm overweight, but it really makes you feel better. And also you get attention, also encouragement from other people. My patients saying you're looking good. So it is a positive feedback from your friends and the family too. So, and health-wise, my cholesterol dropped from 190 to 160. So there is a little bit of everything that really helps the medication. And I don't think it's going to go away. I think it's going to become really more mainstream. And with the kind of extent of that diabetes type 2 in the United States, it really is a health crisis. And uses medication is going to change the healthcare system in the United States.
Which diabetes is horrible for the skin.
Well, it certainly affects a lot with healing and secondary infections. So it's a problem. I really can't say, I think, diabetics do age a little differently. And one of your patients who made the point that she looked a lot younger since she lost the weight? Absolutely, a lot of people. When you lose that heaviness here, as I said, this lower face heaviness does age you because it's associated with sagging. You lose the delineation between the jaw, between the face and the neck. And what's amazing is on even regular patients, when I do jawline treatments, which I usually do is I combine radiofrequency, toxin into the platysma, and filler into the jawline. And I call it the non-surgical lower facelift. Everyone tells me that everyone tells them they think they lost weight and they haven't lost a pound. They see the jawline.
Definition.
When you see the jawline, a person's brain says, well, that's a person who's thinner. Because when you're heavy, you lose your jawline. And you know these compliments you're getting, I would take them with a grain of salt, because who's going to insult their doctor who's about to stick them with a needle?
Only you, Mary, will come with that line.
They're just buttering us up when they tell us that we look good, okay? It has nothing to do with reality.
You're
Doctors,
amazing, Mary.
thank you all so much. And on that note, up next, are GLP-1 medications playing a role in helping couples get pregnant who've been unsuccessful before? A fertility expert and expectant mom are with us next. Stay there. Welcome back, everyone. There's been another finding in women using those weight loss and diabetes injections, and this one you might think is surprising. Nationally, pregnancy rates are increasing in women using the injections, women who before have been trying to conceive without success. And there are a few reasons why this is happening. So here to explain is LSU Health's Dr. Jay Huber III. He's an OBGYN, fertility specialist, and medical director of the Fertility Institute in Metairie, Louisiana. And from Texas, we're also joined by Corinne English. After difficulties getting pregnant, now at 26, she is expecting her first baby in 2 months. She was using Mounjaro, and congratulations to you, Corinne. So, doctor, let me start with you. Why is it that being overweight or toward obesity makes it harder to conceive in the first place?
Sure. So first of all, thanks for having me. And Corinne, congratulations on your success. It's a terrific story. So in general, the menstrual cycle is very highly regulated. And in order for reproductive age women to have the highest chances of pregnancy, the menstrual cycle has a very complicated discussion between the brain and ovary. And anything that can disrupt that conversation, including things like obesity or PCOS or other medical conditions, can reduce your chances of conception.
Because fat is not sitting there doing nothing. It is changing the way your hormones are working?
That's correct. So fat can contribute to not only reproductive hormones like estrogen or even testosterone, but it can also increase the amount of insulin that's needed to maintain healthy blood sugar levels.
Okay, and when your blood sugar is not working right, your metabolism is not working right, then that throws a lot of different systems off.
That's right. So increased levels of insulin not only maintain the ability to correct elevated blood sugars, but if there's extra insulin running around the bloodstream, it can wreak havoc on the ovaries and normal ovulation patterns that we see during the month.
Okay, so it's not the medication that's helping you get pregnant, it's the fact that it's helping you lose weight, your metabolism is more steady, and then your ovaries and the hormones are in the right balance, and then you get pregnant naturally. Did I say that right?
That's correct. So from the dawn of time, providers and patients have been looking for the best route in which to reduce weight. For a while, pills were pills like phentermine or orlistat, and then bariatric surgery was also utilized. And with the advent of these new injectable medications, the GLP-1 receptor agonists, they have proven to be a very, very effective way to reduce weight. And when the weight comes down, that's when the discussion between the brain and the ovary improves, and hence ovulation is much better.
And Dr. Shauna Levy, we heard from in an earlier segment, says that her bariatric surgery patients who lose weight do end up getting pregnant. So Corinne, let's hear your story. So you had a few things going on. You had the weight, which you've lost 60 pounds on Mounjaro, and the compounded version. You have PCOS, polycystic ovary syndrome, and you were pre-diabetic. So what was happening? How long did you try to conceive?
Well, I was diagnosed with polycystic ovarian syndrome when I hit puberty. So I'd always been told it would probably be pretty difficult to conceive naturally. I had really bad cysts all over my ovaries from the moment that I hit puberty. So in August of 2022, when I was borderline pre-diabetic, I had insulin resistance from the polycystic ovarian syndrome, and I was in a metabolic syndrome state. I was really overweight, really unhealthy, and pretty much my body was fighting back against me. So my hormones were kind of wild and crazy. My cysts were pretty much preventing a natural cycle to happen for me. I had really irregular periods. I wasn't ovulating normally. So when I got on the medication, initially without a thought about the polycystic ovarian syndrome, just to hope that I could actually lose weight because my body was in that metabolic state. So the medicine was to help me lose the weight. I lost, like you said, about 60 pounds within about a year. And to our surprise, when I went in for my annual gynecology visit, my cysts were gone. And my hormones started to regulate, and I started having a normal cycle. So from that moment on, my husband and I decided, you know what, this is the healthiest I've ever been. Let's go ahead and try. And we tried naturally for about 7 months. And finally, that 7th month, we got a positive pregnancy test.
And that baby's coming in 2 months. Okay, so Dr. Huber, I know you are not Corinne's patient. She's a doctor. She's in Texas, but these GLP-1s, these injections, they can't make the cysts on your ovaries go away, or because they were there when she went through puberty, before she had the extra weight on her.
That's correct. So in PCOS, what we see is that the ovaries are essentially working in overdrive, and not necessarily cysts, but we call follicles. There are a lot of eggs in the ovary, and the reason why we see the ultrasound images that we do is because there are various hormones impacting the ovary. And again, with that weight loss, the ability of the body to start to regulate and have a regular menstrual cycle, it's something very common that we've been seeing with these incredibly potent medications as the GLP-1 agonists.
So medically, it is possible that when you lose all that weight, those follicles, which we call cysts, there'll be fewer of them?
Certainly possible that it can be reduced. In patients who have a certain form of PCOS, we do see it. There are also patients that have lean PCOS, where their BMI is completely normal, but their ovaries do appear PCOS on ultrasound. But for patients who have PCOS and obesity in combination, as you mentioned earlier, PCOS can make it very difficult for patients to lose weight. But once that weight is lost, then the ability to have the ovaries appear a little bit more normal on ultrasound because the metabolic state is improved.
Wow, are there any downsides to this? It just sounds wonderful for Corinne and all the other couples out there trying to conceive.
So, the only real downsides that we see in patients who spontaneously conceive, meaning not with any type of medications from a fertility specialist or from an OBGYN, as long as the medication is stopped, we don't have much data to suggest that exposure to these medications in early pregnancy is detrimental to the pregnancy. It's not recommended that you continue these medications in the pregnancy at this point.
Because we just don't know.
We don't know. We don't have the data to suggest that. I will say, though, if families are trying to actively conceive, it's also recommended that a 1 month to 2 month interval between the last dose and the time of conception is where we're trying to get.
It's better to get to your goal weight, then stop the medication, and then try to start conceiving.
I'd say that's the optimal approach.
Mm-hmm. So Corinne, you got off of the medication months and months, several months before you conceived. So you don't have to be concerned about any of that. But how has your, the food noise, as they call it, how has that worked for you being pregnant and not being on these medications as far as the calories that your brain wants you to eat?
Yeah, definitely. I will say that when I got off of the medication, the food noise does come back, the hunger does come back, and then the adverse reactions to some foods, that goes away. So it is a lot harder to kind of practice those healthy habits that you learn throughout your time being on the medication. But my body was allowing me to naturally keep this weight off before, because of the insulin resistance with the PCOS and the metabolic syndrome that I was diagnosed with. I was dieting, I was in the gym, nothing. I was still gaining weight. My body would not allow me to lose the weight, even trying diets and exercising. So now that my body is not in that kind of hectic metabolic syndrome state, I am able to kind of watch the things that I eat, be careful with my calorie intake. And of course, I'm a human and I'm a pregnant human. So sometimes it is a bit harder to stay away from those really great indulging cravings. But thankfully, aside from the healthy weight gain that I've had from my pregnancy, I've been able to keep off the weight. The 7 months prior to getting pregnant, I didn't lose or gain any weight, and now I'm just consistently gaining the healthy weight from the pregnancy.
That's wonderful, Corinne. And as we heard earlier from one of the doctors and the researchers, that there are some people who have that dysregulation in hormones with the food noise, and you may have to be on it for the rest of your life. It's just like a postmenopausal woman doesn't have her ovaries making her hormones, so she'll have to be on her hormones to replace them for the rest of her life. So, and how much is it okay to gain during pregnancy? Because a lot of people think you need to eat a whole lot more, but it's not that much more, because you don't want to have gestational diabetes or something like that.
Yeah, so that there are ranges depending on what your pre-pregnancy weight and BMI are, and those can fluctuate depending on what your BMI is for prior to getting pregnant. Yeah.
All right, let's talk about not getting pregnant. There are some people who are concerned, okay, your stomach contents are emptying much more slowly, and will the pill, your birth control pill, get into your blood to prevent ovulation so you won't get pregnant? But we don't really have data on that. So what do you say about that?
Yeah, so the ability for a birth control pill, an oral contraceptive, to work is, number one, has to be taken regularly. And the second thing is adequate absorption through the GI tract. And any medications or treatments that can impact the ability of an oral medication to be absorbed may reduce the overall effectiveness of that medication. So it is a hypothetical / theoretical that a birth control pill in the initial phases of these types of treatments, when there is rapid weight loss or titrating up on doses, that an oral birth control pill could be less effective than desired.
Because the ones you doctors prescribe now are very low dose. That's why you have to take it at the same time every day.
That's right. Some formulations are a little bit more specific. In general, the combined oral contraceptive pill, where we use estrogen and progesterone, those have a little bit more leeway, but some of the formulations with progesterone only, those do need to be taken at the same time every day.
And we mentioned earlier Dr. Shauna Levy, who we spoke with earlier. She believes that when the doctor's titrating up your GLP-1 injection to get you to the maximum dose, that could be over 6 months, it could be over 2 months, whatever that is, that's when you need backup contraception. Do you agree with that?
I'd agree with that. I'd agree, because I think the primary purpose of taking the oral contraceptive is to try and prevent pregnancy. And anything that may disrupt the ability for its highest efficacy or ability to do the job, we would recommend backup contraception.
Corinne, let me ask you on an emotional level. Your life has changed so drastically. It just touches me over this last year or so. A baby coming, the 60-pound weight loss, just, you know, your ovaries being more normal without the cysts. Just tell me on an emotional level, as a young woman, how has this changed you?
When my endocrinologist introduced me to this medication, I was a little nervous because it is a drug that is used to treat type 2 diabetes. It's made and marketed for that. But I was willing to try anything that would give myself a better future, my marriage a better future, and then eventually my future kids a better future. And within the year that I was on that medication, I became a different person. I was extremely hopeful from the moment that I not only started seeing the weight go down, on like that number on the scale, but also just like feeling so much better in my skin as well as with my health. And I can't tell you how I felt and reacted when I went to my gynecologist office and I did that ultrasound. Since the moment I was about 16 or 17, they've always done ultrasounds and saw cysts everywhere. And we just checked in to make sure that everything was okay. And when he did that ultrasound, it was July of 2023. And he said, "Oh, you don't have any cysts." I started crying in my doctor's office because I never thought that that was a reality for me. And then I was able to taper off the medication. I knew that there was a possibility this would be a for life medicine because for many people it is, and that's not a problem. But thankfully for me, my doctors were very confident that my body would naturally be able to take over, and it did. So I think that knowing that there's something out there that could be an incredible resource for so many people, not only just to live a happier, healthier life, but also possibly to conceive naturally, which is something that a lot of us with PCOS fear that is not a possibility. It's changed my life. And then trying, it took us about 7 months and we weren't sure if it was going to happen because again, all of this stuff with the Manjaro/tirzepatide was so new. And once we got those 2 lines, that was something I wasn't sure I'd ever get naturally because of the PCOS. And now I'm 2 months, a little less than 2 months away from bringing this sweet baby into this world. And not only am I so excited, of course, to have that addition to my family, but I'm really thankful and I'm excited that I'm in such a healthier place, a healthier mindset, a healthier physical state to be able to healthily carry this pregnancy, as well as to chase my little girl around the world. I have a lot more energy. I have a lot more happiness. So it really has. It's completely changed my life in every way, shape, and form.
You've emotionally, you've touched my heart because that is everything you've said is so true, and you've changed not only your future, the obvious, everything you stated, but now studies are coming out, Corinne, that it can help prevent or possibly help with things like Alzheimer's in the future, help, lower that, helping with kidney problems. I mean, it's just so many things happen when you have the extra weight and you have the inflammation that you're going to be there healthier. And I was going to ask you, did you want to reveal on television here, but it's a little girl, so very exciting.
It's a little girl, it is. And I truly feel that my little girl would not be possible, at least not yet, without this medication.
On the next Message Meg, women are coming from around the world to New Orleans for the latest in natural breast reconstruction after breast cancer. We'll have surgeons who are performing reconstruction to make women completely whole again. We'll have patients show us reconstruction surgeries that were poorly done and came to this center to be restored. Patients will give personal stories and show their successful health and cosmetic results. And we'll show you a groundbreaking procedure that gives women back real, natural areolas and nipples, not tattoos. An advocate and attorney who has had breast cancer herself will also educate us on what you need to know about insurance. That coming up on the next Message Meg.